Imagine stepping on a scale and, realizing that in just 5 years, you've lost up to 20% of your entire skeletal mass.
Yeah, that's a terrifying thought.
Right. And for some women navigating the menopause transition, that is not some dark sci-fi scenario. It's an actual documented medical reality.
It really is. And, welcome to today's deep dive. We are opening up a massive stack of sources today,
We really are. We've got NHS clinical guidelines, specialized oncology reports, and protocols from the British Menopause Society.
all to look at what happens when the standard menopause path becomes, well, a high-risk minefield.
Exactly, because for the vast majority of women, menopause care is relatively straightforward, right? You
Yeah.
experience symptoms, you see your primary care doctor, maybe they suggest lifestyle tweaks or prescribe standard hormone replacement therapy.
Right, standard HRT,
Yeah.
and your quality of life improves. But our sources today focus entirely on the exceptions to that rule.
Yes, our specific mission today is looking into the question: what specialized medical teams and clinics should a woman see for a complex, high-risk menopause management?
Because it's a completely different landscape.
Mm.
If you're a woman facing breast cancer, or you have a history of severe cardiovascular disease or a clotting
Or
disorder.
if your ovaries stop functioning before you even turn 40.
Exactly.
Yeah.
In those cases, standard HRT might not just be ineffective, it could actually be actively dangerous.
Which is wild. So let's explore the exact clinical frameworks and those dedicated specialists that exist to untangle these tricky biological knots. Where do we even start?
Well, to understand how the medical system handles this, we first need to look at how they categorize risk, right?
Mm.
The British Menopause Society, or BMS, they don't just treat menopause as a single entity.
Right, that's not one size fits all.
Not at all. They've established a very rigid escalation pathway, breaking care down into 3 distinct levels.
Okay, so what are the levels?
So level 1 and level 2 care encompass that standard experience we
Yes.
just talked about. This is your local GP or maybe a primary care physician with like an extended role in women's health.
So they're the ones handling the initial HRP prescriptions, the standard hot flushes, that sort of thing.
Exactly. Routine annual follow-ups.
Yeah.
That covers about 95% of the population.
But what's the clinical tripwire, I guess, that pushes a patient out of that safe zone and into level 3?
The triggers for a level 3 referral are highly specific, and they usually indicate some sort of systemic complication.
Like what?
For example, if a patient experiences unscheduled bleeding after 6 months of being on continuous HRT,
Wait, why 6 months? Like, what makes that specific time frame a red flag?
it's all about how the uterine lining reacts to hormones. I mean, a little irregular bleeding is pretty common when you're first starting or adjusting HRT.
That makes sense. The body is adapting.
Right. But after 6 months, the body should be fully acclimated.
Mm.
So if bleeding persists or suddenly restarts, it raises the suspicion of endometrial hyperplasia.
Endometrial hyperplasia, that's a thickening of the womb lining, right?
Yes, and it can sometimes be a precursor to cancer. So a standard GP just isn't equipped to investigate that safely while also managing the ongoing menopausal symptoms.
Right. They need to hand that over. What's another trigger?
Another major one is a personal history of venous thrombosis, which is a blood clot or a stroke.
I'd imagine that's because introducing certain types of oral estrogen can increase blood clotting factors in the liver.
Exactly.
So you're taking a patient who already has a hair trigger clotting system and potentially adding fuel to the fire.
Precisely. Now, transdermal estrogen, like patches or gels, those bypass the liver, so they don't carry that same clotting risk. But a GP still won't take that gamble,
Oh, interesting. So they still escalate it.
always. That patient needs a level 3 menopause specialist who can carefully weigh the specific vascular history against the exact hormone delivery method.
That makes me wonder about the title itself. We see so many wellness trends and like hormone coaches online right now.
Oh, definitely.
So is menopause specialist a protected term? Or can any clinic just slap that on their website to attract patients?
No, it is a rigorously protected and regulated term like within the NHS and recognized medical frameworks. You don't just declare yourself a level 3 specialist.
So what does it actually take?
These healthcare professionals, and they're usually doctors, independent nurse prescribers, or pharmacists, they must hold the BMS Advanced Certificate in the Principles and Practice of Menopause Care.
Wow, okay. So this isn't like a weekend seminar they took at a hotel conference room.
Not at all. It requires hundreds of hours of peer-reviewed education. plus supervised practical training in complex clinics.
That's intense.
Yeah, they have to demonstrate the ability to manage patients who fall entirely outside standard clinical guidelines.
Well, it makes total sense that you'd need that level of rigor, especially when you look at the most daunting scenario in our source material.
The intersection of menopause and breast cancer.
Yes. The biology here just feels like a devastating catch-22.
It really is. Because breast cancer treatments, specifically chemotherapy or anti-estrogen drugs like aromatase inhibitors and tamoxifen, they don't just casually bring on menopause.
Right, they plunge the body into it almost overnight.
Exactly. And from what the oncology reports detail, these drugs are actively designed to starve the body of estrogen.
Right, because if a tumor is estrogen receptor positive, estrogen is essentially the fuel keeping the cancer alive.
Exactly. So the medical team has to shut down the body's estrogen factories completely.
Wow.
Aromatase inhibitors, for instance, they block the enzyme that converts other hormones into estrogen in the body's fat tissues. They literally drain the tank dry.
Which causes vasomotor symptoms, right? The
Mm.
severe hot flushes and night sweats.
Yes, and they're often far more violent and debilitating than natural menopause. But because the cancer feeds on estrogen, systemic HRT is strictly contraindicated.
So you cannot use the one tool that is universally proven to fix the symptoms.
Exactly. You're stuck.
It's like a high-stakes game of biological tug-of-war. The oncologist is pulling the rope to save your life from cancer by eliminating estrogen.
Right.
But that exact action is pulling you towards severe menopausal aging and daily suffering. You need a hyper-coordinated team to keep the rope from snapping.
That is exactly the rationale behind joint oncology gynecology clinics.
Joint clinics.
Yeah, our sources highlight models like the Macmillan Combined Specialist Menopause and Oncology Clinic. In these rooms, you have the oncologist and the BMS Level 3 specialist sitting right next to each other.
Okay, so they're working in tandem.
Yes, and they specialize in finding non-hormonal escape valves for the patient.
Let's get into the mechanics of that. If you can't give them estrogen, how are these clinics stopping the severe hot flushes?
Well, they utilize entirely different pharmaceutical pathways. For example, they might prescribe certain antidepressants known as SSRIs or selective serotonin reuptake inhibitors.
Wait, really? I think most people associate SSRIs purely with treating depression or anxiety.
Yeah, that's the common perception.
So how does tweaking serotonin stop a physical hot flush?
It all comes down to the hypothalamus. That's the brain's internal thermostat. Now, estrogen usually helps keep that thermostat stable.
Okay.
When estrogen vanishes, the hypothalamus gets confused. It falsely senses that the body is overheating and triggers a massive sweat response to cool you down.
Which is the hot flush.
Exactly. And serotonin is a key neurotransmitter in that exact thermal regulation center.
Oh, wow.
Yeah, so by using an SSRI to stabilize serotonin levels, they can essentially reset the broken thermostat without introducing a single drop of estrogen.
That is fascinating. The sources also mention something called clonidine being used in these clinics. Isn't that a blood pressure medication?
It is, yeah. Clonidine acts on the central nervous system to relax blood vessels, and that dampens the physiological reaction of the hot flush.
They also lean heavily on cognitive behavioral therapy, right? CBT.
Yes, they do.
Which, just to be clear, isn't about telling a woman her hot flushes are, like, all in her head.
Oh, no, absolutely not. CBT in this context is about managing the nervous system's reaction to the flush.
How so?
It helps lower the stress hormones that often exacerbate the frequency and intensity of the physical symptoms.
So it's about breaking that panic loop. But the clinical tightrope walk doesn't stop at hot flushes.
Far from it.
The sources detail incredibly complex debates inside these joint clinics regarding localized treatments, specifically the genitourinary syndrome of menopause, or GSM.
Right, and GSM is severe. We're talking about profound vaginal dryness, tissue atrophy, and recurrent urinary tract infection.
It can completely destroy a patient's quality of life.
Absolutely. And the standard treatment for GSM is a localized estrogen cream, or pessary, inserted directly into the vagina.
But wait, if you have an estrogen-responsive cancer, wouldn't putting estrogen anywhere in the body be a massive red flag?
And that is exactly what the oncologists and the menopause specialist have to debate in those joint clinics.
Oh, I see.
Modern topical estrogens are designed to stay localized in the vaginal tissues with, like, microscopic systemic absorption.
But it's still a risk.
Yes. So for some breast cancer survivors, the joint clinic will determine that the microscopic risk is worth restoring the patient's ability to walk without pain or engage in intimacy.
It's a highly individualized, fiercely monitored decision.
It really is.
You know, it's wild to think about the visible, loud trauma of cancer treatments crashing into menopause. But what really unsettled me in the clinical guidelines were the silent threats.
The ones happening under the radar.
Exactly. The changes that you can't feel at all until it's too late. I'm looking specifically at the data on cardiovascular shifts and bone density.
Estrogen is the great protector of the female cardiovascular and skeletal systems. When it retreats, you basically lose your internal armor.
Let's break down the heart first. The sources highlight specialized women's heart programs and menopause cardiology clinics.
Yes, they do.
And I found myself wondering, why can't a regular cardiologist handle a menopausal woman with heart palpitations?
Because the overlap in symptoms is incredibly deceptive.
Yep.
I mean, menopause itself can cause severe heart palpitations, crushing fatigue, and even chest tightness just from intense vasomotor episodes.
So it mimics a heart attack.
Yes. But simultaneously, the actual risk of true cardiovascular disease skyrockets post-menopause.
Right, because estrogen helps regulate lipid profiles. It keeps the good HDL cholesterol high and the bad LDL cholesterol low.
Exactly. And it also helps keep the blood vessels flexible.
So when the estrogen drops, the LDL spikes, the vessels stiffen, and arterial plaque can suddenly build up incredibly fast.
Which is a perfect storm. So when a 50-year-old woman shows up with a racing heart and chest discomfort, a standard evaluation might dismiss it as just menopause.
Or, conversely, they might over-medicate her for a heart condition she doesn't even have.
Right. And that's why specialized cardiology teams are there to unmask the root cause.
How do they do that?
They use advanced vascular imaging and specific metabolic panels to determine if it's just a harmless menopausal arrhythmia or if it's early-stage ischemic heart disease.
And crucially, they dictate whether HRT is a weapon or a liability for that specific heart.
That's the exact calculation they make. If her vessels are still healthy, HRT might protect her. But if she already has advanced plaque, oral HRT might destabilize that plaque and actually cause a heart attack.
That is terrifying. And that same level of specialized forensic work is required in metabolic bone clinics too, right?
Absolutely.
This brings us back to that statistic from the beginning of our deep dive. Women can lose up to 20% of their bone density in the 5 to 7 years immediately following menopause.
It's staggering.
How does the body cannibalize its own skeleton that fast?
Think of your bones as a continuous construction site. You have cells called osteoclasts, which are the demolition crew breaking down old bone.
Okay, osteoclasts demolish.
Right. And then you have osteoblasts, which are the construction crew building new bone.
Got it.
Now, estrogen is like the site manager that keeps the demolition crew in check. So when estrogen drops, the osteoclasts go into overdrive. The demolition dramatically outpaces the construction.
So the bone literally becomes hollowed out and brittle, which is osteoporosis.
Yes. So for high-risk patients, those with a family history, early menopause, or who have been on medications like steroids, metabolic bone clinics step in.
And then what do they do differently?
They utilize DEXA scans. That stands for Dual Energy X-ray Absorptiometry.
Okay, DEXA scans.
Yeah, it uses two distinct X-ray beams to precisely measure bone mineral density. They typically focus on the lumbar spine and the hip, which are the most catastrophic places to suffer a fracture.
So if a DEXA scan shows a woman is already in the danger zone, but she's, say, a breast cancer survivor who absolutely cannot take HRT to restrain those demolition cells,
Right.
what do the bone clinics do? Is she just waiting for her hip to break?
Absolutely not. These clinics have an entirely different arsenal of medications, primarily a class of drugs called bisphosphonates.
How do bisphosphonates work without hormones?
They directly target those overactive osteoclast cells. The bisphosphonate binds to the bone matrix, and when the osteoclast tries to break down that bone, the drug essentially disables the cell.
Oh, wow. So it freezes the demolition process.
Exactly, it just stops it.
But the sources note that these clinics have to monitor patients on bisphosphonates incredibly closely.
They do, because bone actually needs some turnover to remain flexible and healthy. If you freeze the demolition process completely for too many years, the bone can become brittle in a different way.
Oh, geez.
Yeah, leading to very rare but serious issues like atypical fractures of the femur or osteonecrosis of the jaw. So it's a very delicate balancing act.
They also prescribe mechanical loading, right?
Yeah.
The clinical guidelines emphasize targeted resistance training. It's not just like, make sure you go for a walk.
Right, walking is wonderful for your heart, but it does very little for bone density. Bone responds to physical stress through a process called mechanical loading.
So lifting weights.
Exactly. When you lift heavy weights or use strong resistance bands, the muscle pulls forcefully against the bone.
And that signals the construction crew to fortify the area.
Yes, it tells the osteoblasts to get to work. The bone clinics literally prescribe heavy lifting alongside the pharmaceuticals.
It is just brilliant how mechanical the body is. Now, cardiology and bone clinics are doing the heavy lifting literally to keep a woman alive and physically intact.
They are.
But we also have to look at the clinics dedicated to how a woman actually experiences her daily life and relationships. Which brings us back to genitourinary syndrome of menopause, but from a rehabilitation perspective.
Yes, the structural changes of GSM, the thinning of the vaginal tissues, the loss of elasticity, the change in the vaginal microbiome that leads to endless UTIs.
It's awful.
It creates a cascading physical and psychological trauma.
The sources highlight two specific, often overlooked specialists here: pelvic health physiotherapists and psychosexual therapists.
Crucial teams.
I look at this dual approach like fixing a malfunctioning computer. The pelvic physiotherapist is there to repair the broken hardware.
I like that analogy because when a woman experiences dyspareunia, which is pain during sex due to those thinned estrogen-deprived tissues, her body doesn't just ignore it.
Right, it reacts.
The pelvic floor muscles will reflexively tense up to protect her from the anticipated pain. It's a subconscious guarding mechanism.
So even if she wants to be intimate, her body is bracing for impact.
Yes. And over months or years, this leads to chronic muscle spasms. So even if you fix the tissue later with topical estrogen, the muscles are still locked in a state of defense.
Wow. So a pelvic health physiotherapist physically goes in to disarm that defense system.
Exactly. They use manual therapies to release the muscle tension, retrain the reflexive guarding, and stimulate blood flow back into the pelvic floor.
They are rehabbing the hardware.
Right. But to finish your computer analogy, fixing the hardware doesn't matter if the software is corrupted.
And that is where psychosexual therapy comes in.
Precisely. Because the brain's pathways have been rewritten. The brain has literally learned to associate intimacy with pain and anxiety.
And psychosexual therapy isn't just generic couples counseling, right?
No, it is highly specialized. It's recognized by major health bodies like the NHS and regulated by organizations like QSRT, the College of Sexual and Relationship Therapists, and the BACP.
So what do they actually do in session?
These therapists work on the emotional fallout. They help individuals and couples dismantle a fear of pain, navigate the profound loss of libido that can accompany hormonal drops.
And repair the shame and body image issues that arise when a woman feels her body has just betrayed her.
Yes. And the clinical data shows that when you pair the physical physio with the psychological therapy, the physical outcomes actually improve faster.
Because the mind and the pelvis are intimately connected.
You cannot treat one without treating the other. It really requires a unified approach.
Now, everything we've explored today, the bone clinics, the oncology teams, the pelvic therapists, generally applies to women navigating menopause in their late 40s or 50s, or those forced into it by cancer.
Right, the typical demographic.
But there is one major glaring exception to this timeline in our sources, a condition that requires its own dedicated clinics. Premature ovarian insufficiency, or POI.
Yeah, POI completely shatters the expected timeline.
How early are we talking?
Well, it affects roughly 1% of women under the age of 40, and a smaller fraction experience it in their 20s or even their teens.
That is heartbreaking.
It's characterized by the ovaries losing their normal function decades before natural menopause is supposed to occur.
So you have a 28-year-old woman suddenly dealing with hot flushes, night sweats, and her periods just vanishing. How do these specialized POI clinics or reproductive endocrinologists actually prove what's happening?
They look closely at the communication loop between the brain and the ovaries, specifically by measuring follicle-stimulating hormone, or FSH.
How does that loop work?
Think of the brain as a thermostat and the ovaries as the furnace. The brain produces FSH to yell at the ovaries, telling them to produce estrogen.
Okay, so FSH is the signal.
Right. If the ovaries are struggling and don't produce the estrogen, the brain doesn't just give up. It starts screaming.
Meaning it produces more FSH.
Exactly. It pumps out massive, elevated amounts of FSH, trying to force the ovaries to work. So if a clinician sees consistently sky-high FSH levels on blood tests taken a few weeks apart.
It confirms the diagnosis of POI.
Yes, and the treatment protocol here is radically different. For an older woman, HRT is a choice for symptom management.
But for a woman with POI?
The clinical guidelines state that HRT is an absolute non-negotiable medical necessity until they reach the natural age of menopause around 51.
Wow. Non-negotiable.
It is about damage control. We just discussed the catastrophic effects of low estrogen on the heart and the bones.
Right. So if a woman loses her estrogen at 28, she is facing over 20 extra years of accelerated bone demolition and arterial stiffening compared to her peers.
The HRT isn't just to stop hot flushes. It is to replace the physiological baseline of hormones she needs to literally survive the next 2 decades without severe osteoporosis or a massive heart attack.
That makes total sense. But I need to challenge the terminology used in some of these older clinical papers because it's deeply confusing.
Oh, I know exactly what you're going to say.
It used to be widely called premature ovarian failure, but the guidelines explicitly note that 5 to 10% of these women can still conceive naturally.
Right.
So how can an organ that has failed still produce a baby?
That paradox is exactly why the medical community shifted to the term insufficiency. True premature menopause means the ovaries have permanently and completely shut down. The vault is empty.
But in POI?
In POI, the ovaries are just unpredictable. They might lie dormant for a year and then suddenly sputter to life, release an egg, and produce a surge of hormones before shutting down again.
So they are essentially malfunctioning, not completely dead.
Correct.
Which means if a patient with POI does not want to get pregnant, they still have to use birth control because standard HRT is not a contraceptive.
Exactly. And conversely, if they do want to build a family, the reproductive endocrinologists at these specialized clinics have to step in.
To help with fertility preservation.
Yes. Because the remaining egg pool is so depleted and unpredictable, standard IVF using the patient's own eggs has a very low success rate.
So what are the options?
These clinics provide intense psychological and medical support to guide patients toward utilizing donor eggs, which is the most reliable pathway to pregnancy for a POI diagnosis.
It is a profound emotional journey that requires an entire ecosystem of support, which really brings us to the core realization of this entire deep dive.
That it takes a village.
Exactly. Navigating a complex, high-risk menopause requires a village. If you have a complicated medical history, if you are fighting breast cancer, protecting a vulnerable heart, or facing premature insufficiency in your 30s,
You do not have to accept the standard path if it feels like a minefield.
the infrastructure is there.
Sure.
From the BMS Level 3 specialists and oncology teams to the metabolic bone experts and psychosexual therapists.
You just need to know these clinics exist so you can advocate for the exact referral your body requires.
Absolutely. So, as we close this deep dive, we want to leave you with a final thought. We spent this entire time looking at how human medicine tries to manage this systemic shift.
We did.
But looking at the sheer scale of the biological changes involved, it raises a much larger question.
It really does. Because we've talked entirely about human biology today. But here is something to ponder as you log off. Out of the millions of species on Earth, only humans and a handful of species of toothed whales actually experience menopause.
Wait, really? Just whales and humans?
Yeah. For killer whales, the postmenopausal females become the crucial leaders of their pods. Free from the biological tax of reproduction, they guide their families to food during desperate times and ensure the survival of their entire lineage.
Oh, wow. That is amazing.
It makes you wonder, if evolution designed this profound total body metabolic reset so purposefully in nature, how much more is there to uncover about the biological power and advantage of this exact phase of human life?
It completely flips the script. It's not a failure of the body. It's an evolutionary graduation. And when you look at it that way, demanding the specialized care you deserve to navigate it doesn't seem complicated at all. It seems essential.